Welcome to the Johns Hopkins Women's Health Podcast, A Woman's Journey. Insights that matter. I'm Kelly Gear-Ripken, and I invite you to listen to Johns Hopkins specialists discuss the latest topics in women's health. Now here's your host, Lily Shockney.
Hi, this is Lily Shockney from A Woman's Journey at Johns Hopkins, and this is our podcast, Healthy Insights That Matter. According to the Skin Cancer Foundation, in the United States, more than 9,500 people are diagnosed with some form of skin cancer every day. Let me say that number again. More than 9,500 people are diagnosed with some form of skin cancer every day. More than 2 people die of the disease every hour. In this month's podcast, I serve as your moderator again, and I am joined by dermatologist Dr. Farah Sukhariya, an assistant professor of dermatology at Johns Hopkins. Her research interests focus on immune checkpoint inhibitors and the role of the tumor microenvironment in various cancers, including melanoma and squamous cell carcinoma. So welcome, Dr. Sukhariya, and thank you so much for joining me today to talk about this important subject now that we're entering into summer.
Thank you so much. I really appreciate the opportunity to be talking to all of you today.
Well, we're happy to have you too, I can assure you that. So let's start with, how many different types of skin cancer are there?
Skin cancers are pretty common. Actually, skin cancers are the most common form of cancer, and 1 in 5 Americans are going to get diagnosed with skin cancer. Now, when we classify skin cancers, they're generally classified into melanoma, which is the deadliest type of skin cancer, and non-melanoma skin cancers, such as basal cells and squamous cell carcinomas. But the difference between those three is the cell of origin. So basal cells and squamous cells, they actually imitate their ancestors, which are the keratinocytes or the skin cells. But in terms of skin pathology and histology, it's the suprabasal layer. That's why they're non-basal cells. Basal cell carcinoma, on the other hand, is actually originating from the basal cell layer of the cell only. The counterpart, of course, is the melanoma, which originates from melanocytes, which are the pigment-producing cells. But we should always remember that even though most of the melanomas, yes, tend to have pigments in them, sometimes melanoma actually does not have pigment, which is pretty scary as well.
That would be scary because we need to find it early. And if it's not appearing on the skin, even though it could be tiny, but kind of standing out there with discoloration of the skin, then the person isn't going to know it. I think that a lot of our listeners don't realize the true difference between melanoma and non-melanoma. One has the ability to kill you, and the other one is far more treatable. People just hear skin cancer, and oftentimes they assume, well, it's one thing, when in fact it is not. When we're looking at the prevalence of these 3 types of skin cancers, what kind of incidence is there for, say, the non-melanoma ones, the squamous and the basal cell, versus melanoma?
In terms of the incidence of the types of skin cancers, basal cell carcinoma is the most common form of skin cancer, which is actually a good thing because basal cells are, of course, between quotations, they're the nicer form of skin cancer. What I always tell my patients is if I had to choose one, I would definitely choose basal cell instead of other types of skin cancers. However, although, as you said, they rarely metastasize and they leave the area that's involved to go somewhere else, which is actually always a bad prognosis, they are locally destructive, meaning that if we leave them for many years untreated, they are able to invade the tissue that's under it and obviously cause local damage. Although in my experience, I've also seen metastatic basal cell. It's rare, but it can happen, especially if it's a location that is missed or harder to treat. Second in line are the squamous cell carcinomas, which, again, they're not melanomas, they're not the worst, but they're still pretty bad in the sense that they have a higher chance to metastasize, meaning they can go somewhere else. And then they are also, as well as locally destructive, but they tend to be symptomatic. They can be painful. Patients usually say this is really rapidly getting larger in size, etc. And we do have high-risk areas, for example, like the lips and the ears. These also have a higher risk to metastasize and have a worse prognosis. And of course, the third type of cancer, which is melanoma, the deadliest form, it happens pretty commonly but not as common as squamous and as basal cells. And when I say commonly, of course, compared to our dermatology world, we are seeing way more melanomas than we used to see before. But part of the reasoning is we are able to detect it earlier. And so that's a good thing. That's a good sign because it means that patients and physicians are actively looking for melanomas and they are finding them.
So can you elaborate a little bit on the stages of melanoma?
So melanoma can happen early on. We call melanoma in situ. Whenever we say in situ, it means the pigment producing cells, which are obviously now they're cancer cells, they're only living in the epidermis. So the melanocytes, although they're trying to be funky and not behaving, but they're still in the epidermis. So this is called melanoma in situ, which is the earliest form of melanoma, and of course, the best to treat. Then we go to different stages where the pigment producing cells or the melanocytes, the funky ones, are now in the dermis, so in the deeper part of the skin. And so this is what is termed as invasive melanoma, which obviously has the worst prognosis, depending on the depth of it. So the deeper it is, the worse it is. And if it goes to the lymph nodes, the neighboring lymph nodes, this is one thing. And if it goes distant, that's another thing. That is even worse. The good thing, though, the 5-year survival rate of melanoma, when it's detected early and it's just in the superficial skin hanging out, it's almost 99%, which is great, right? In terms of the cancer world, that's amazing.
Absolutely.
But if it starts to spread to the sentinel lymph nodes, meaning the lymph nodes that are close to the tumor, then that 5-year drops to 68%. And then if that melanoma goes really far, distant lymph nodes or other organs, then that 5-year survival can drop up to 30%. Early detection is key to get the 99% survival rate.
I think, too, when we are visually looking at a melanoma, we might be assuming that, well, it's just this little tiny thing that's the size of a pencil eraser. And patients don't understand this is kind of like an iceberg, that what we see on the surface may not be representative of what's deep below it. And as you mentioned, that measurement of how deep down does it go is factored into the staging of the cancer. You mentioned the lips and the ears. I've also heard about the bottoms of your feet being something that we may not pay attention to other than walking on them, but we may not be looking at the bottom of our feet or in between our toes or even at our toes for that matter. So when someone is doing a skin check of themselves, just how far should they go? Should they be looking at their scalp? Should they be looking at the bottom of their feet? Or is it okay to just focus on that which they believe is exposed to sun?
That's an excellent question. As deep and as far as they can go, because the more they see, the better. This is such a crucial thing to be aware of because we sometimes miss a few hidden areas, right? So obviously, as much as we're able to see, the better. The back, for example, is a tough area. So that's why it's shown that patients who have somebody living with them or caring for them, they actually tend to live longer. That's what I tell my patients because their partners are usually able to detect certain changing molds, for example. And so they are definitely at a better prognosis because we catch it early. But other areas that are involved that we tend to sometimes forget about, the eyes are one of them, the lips, the inner mucosa. So when we ask the patient, you see the dentist every time, make sure you mention if there are any darker spots in the insides of your mouth, the eyes, same. And of course, genitals, whether it's the primary care for males or urologists or the GYN for female patients. Of course, we examine the genital area as well, but we also encourage the GYN to examine, for example, the sensitive areas. In terms of feet, for sure. So acral areas, classically the feet and the hands, between the toes and the nail bed as well. Patients who use, for example, nail polish, we always recommend that when we see them, they take off their nail polish to check the nail for any pigmentation. We are seeing a little bit more incidence of nail melanoma because we are getting more and more exposure to UV, even with our hands, for example, with patients who use gel polish. But it's so important to remember that every single point on your body is equally important. And you had mentioned also the scalp. Things can hide in the hair, behind our ears.
Am I correct in saying that you don't need to have gotten a sunburn in your past history, for example, of your genitals? It doesn't require that you've been bathing in the nude in order to end up with, let's say, a melanoma down there.
Without a doubt. So this brings us to what gives us skin cancer, right?
What are those risk factors?
Number 1, 2, 3, 4, 5 are UV rays. Being in the sun is definitely a huge risk factor for non-melanoma and melanoma skin cancers. This is number 1. Number 2, radiation exposure. So patients, let's say, who've had breast cancer, right? And they've had radiation to the breast area. They're at a higher risk for developing cancer at the site, chronic ulcers, certain exposures, for example, to arsenic. So these are all from the outside. Tanning bed use, as you had mentioned, definitely increases our risk for melanoma and non-melanoma skin cancers. But then you might say, what about those non-exposed areas? So non-exposed areas, obviously, they're theoretically not exposed to the sun. But when patients have a history of tanning bed use, that criteria does not fit, because usually you're doing the indoor tanning without much clothing on. So this is number 1. Number 2, it was shown that patients who have more melanin, patients of skin of color, tend to have as well skin cancers. And those skin cancers are not necessarily UV induced, like sun exposed or sun induced skin cancers. They're not. Acral skin, so again, hands and feet. So melanoma tends to happen actually in patients of skin of color in hands and feet and nails. The problem with that is that most of the time it gets diagnosed later on, and this is a little bit harder to treat.
More than 50 years ago, when I was in nursing school, I had a patient who said to me, if you can help me wash up as far as possible and down as far as possible, I will then wash possible. And so I learned that was her genitals, which I thought was very funny. So I think that what we're asking people to do is to check their skin up as far as possible, down as far as possible. And then let's also take a look at possible as well. And I definitely understand what you're saying about living with someone and that they really have a bird's eye view of the 360 degree of their loved one. I diagnosed my husband, it's been 15 years ago. Since then, he's had 3 more melanomas. So that one was on his chest. And then he had one on his buttocks, which he was very distressed about because he doesn't have a whole lot of tissue back there. And then they took away all that he had. He was like, I don't like this at all. And
poor guy.
One on top of his head. And then also one under his shoulder blade. Even though they were small, one was stage 0, thank heavens, the others were stage 1. The amount of tissue that needed to be removed, as well as checking that sentinel node, the guard node, the node that's closest to that tumor bed, was very surprising to him as a patient. Even though I said, you're going to have a big section of tissue for this one, I think they're going to pull you together with rope, get things to close okay. And he was like, really? And I went, yeah, I think so. So, of course, I'm checking him all the time, looking at him head to toe to see, do we have anything new that's popping up? And he sees his dermatologist regularly as well. Though he's assured me he never sunbathed in the nude. That's what he told me.
Good.
I don't know that's true, but that's what he's told me. He was, at one point in time in his youth, a lifeguard. And he actually applied baby oil to his skin mixed with some iodine in it. And I'm like, what the heck did you do that for? So I could get really, really tan. He said, I look like a brown bear by the end of summer. I'm like, that was a really bad idea.
I'm glad he's okay. I hope that he stays healthy. And of course, with the checks and everything, I'm sure he'll be okay. But yes, that's a very common practice. At least I would hope it was in the past, where people just put body oil and mix with all random things. And we see that a lot still in some areas of the world, where it depends on every culture and every background. But now we know that there's no such thing as a safe tan. There's no such thing as a fun, nice tan. We can do self-tanners. You can do whatever foundation, whatever you like, right? I'm sure some people prefer to look tan, but that doesn't matter. There's no safe tan because, as you said, the main risk factor is UV exposure. But not only that, is the blistering sunburns that we get. Even as a number as low as 5 blistering sunburns are enough to increase our chances of having skin cancer, melanoma, even sometimes close to 80%, or non-melanoma skin cancer like close to 70%. So even a few blistering sunburns, especially at a younger age, That being said, with your husband, probably they were covered areas. Genetics plays a huge role in skin cancers in general, mainly in melanoma. It tends to run in families. But also for the non-melanoma skin cancers, there are certain rare genetic diseases where they get multiple basal cells, for example. Mainly in melanoma, we always ask about the family history because it helps us when we are examining them. We just become a little bit more annoying in examining them.
I'm aware of the BRCA2 gene mutation since I work in the breast cancer world, and we always get that family medical history to see, does she have other people with breast cancer in her family? How about ovarian? How about melanoma? How about pancreatic? Patients are always surprised saying, why would you ask me about those? And there's a good reason. It's because of the genetic predisposition. And do we need to do genetic counseling and testing or not? Certainly can be an issue. When we're looking at ultraviolet rays and we're in the pharmacy buying sunblock, and they've got all ranges of sunblock, including, I noticed they have some that say they're for babies. It's what it says. And I'm like, would I put that on a baby? I think I would have the job totally covered up personally, but it kind of implies take your baby out in the sun. It's fine if you use this baby sunblock. It'll say that it's number 50 or number 80. Or if you are going to be out in the sun and you can't get away from the sun for whatever activity you're doing, what do you recommend other than wear a big hat and hopefully long sleeves? But for people to say, I can't do that. I'm in a situation where I'm surfing on my surfboard. I can't wear a hat.
First, let's talk about that. And then, of course, we'll talk about the sunblock specifically. So the way we counsel patients is we say we try to avoid the sun exposure during midday. Whatever you want to do, try to be at a time when it's really not that hot and not that sunny. So earlier in the morning or later in the afternoon towards the evening. So this is one thing. If they're able to do that, it's great.
The 10 to 2 rule is what you're recommending?
I would say like 10 to 4. But again, I'm annoying. Yes. But again, as you said, also protective outerwear, right? So first, having a wide brimmed hat, because people sometimes would put on like just a baseball cap. That's not enough because as we said, ears are a very high risk area anyway. So a wide, big hat. I always say like the bigger, the uglier, the better. And then the sunglasses. But then in terms of outfits, now we have protective clothing that protect us from the sun specifically. It's kind of like wearing a sunblock all over and always reminding ourselves that it's nice to be in the sun. I'm not saying no. And life is enjoyable and we have to enjoy every second of it because it is short. We also want to live longer and healthier. So enjoy life, but also protect ourselves. So then we talk about the sunblock. I like to call it more like sun protection because when we say block, we feel more at the safe zone, which is not entirely true because I wish the cream that we put on protects us from the sun or blocks the sun forever, right? It doesn't. But we have to put on anything you like, sunscreen, sunblock, sun, whatever you want to call it, especially if we have to be outside. Mind you, even if we're inside, we have to wear sunscreen because part of the UV rays, like UVA instead of UVB, penetrates through the glass window as well. So even now, like for example, I'm talking to you and there's some sun, I am wearing sunscreen. Reapplying it every 2 hours and put like a nice amount. So not just like a tiny thin film. And then ideally, it has to cover every type of UV ray. So it has to be broad spectrum, which means it covers UVA and UVB. And even though it says water resistant, it doesn't matter. Please reapply every 2 hours. And then lastly, about the SPF. So SPF stands for sun protection factor. We sometimes feel like if we put SPF 100, we're protected the whole time. The same rule applies every 2 hours. But the guidelines say that we have to use SPF more than 30. So 30 plus is what we're aiming for. Some creams are advertised as having sunscreen in them. But if you look really closely, their SPF is 15. Makeup, for example.
And they're always 15.
They're always
I haven't 15. Seen anything higher.
So even if you're using that, ideally, the last thing you want to use on your face is a sunscreen. As for our babies, the recommendations are after 6 months. This is what I use for my kids. Even with that, the big hat, the protective clothing, and trying to avoid the blistering sunburns for them, because as we said, the younger they are, the higher risk in the future of developing skin cancer.
So as we talked about, there's 15 SPF, there's 80 SPF. Do
Yes.
you recommend, if it is available in your local stores, to go with the 80 or at least 50 or?
Not necessarily. Anything SPF more than 30 should be fine. I always recommend to the patient to choose a sunscreen they like, because that sunscreen will be their bestie, right? So in terms of color, texture, brand, smell, price, anything, right?
And not sticky.
And not
I know
sticky.
that's a deterrent. It's a barrier for people using
For
sunblock. Because they'll say, I feel sticky. Well, then
For
they aren't
sure.
going to want to use it.
For sure. So drug companies are definitely aware of that. So they formulated different types and smells and colors of sunscreen to accommodate all patients' preferences. Of course, if it's lightweight, people tend to use it more often. Now we have tinted ones, which also help with not looking like a ghost, which I totally get. We've all been there and we understand. As long as whatever you like, keep using it every 2 hours, reapplying it, making it part of our routine. There are two types of broad categories of sunscreens. So the mineral sunscreens tend to be more white and cakey and pasty, whatever the word is. So basically these are thicker, they're sticky and sometimes a little bit more annoying. I get it, but they definitely have a strong trait to protect us from the sun. The chemical sunscreens, they scatter the UV rays. They tend to be a little bit lighter. Patients sometimes like them more. For patients with sensitive skin, might not be the best scenario. So for sensitive skin, we go for the ghosty ones.
Sounds like we need to have society embrace paler looking skin, because there is this, if I don't look tan, that I won't look pretty or I won't fit in. If we can adopt a different opinion to this of having lighter skin be considered what is the most attractive. Maybe we need to adopt the geisha philosophy, right? Geishas are Snow White.
They have the right mindset.
I'm sure their incidence for skin cancer is probably quite low compared to, say, here in the United States.
Yes, and for sure, like patients who are, as you said, like a surfer or a lifeguard or just by the coast, living and having fun. Again, we're not opposing that at all. In terms of color, yes, healthy skin is the best skin ever. Healthy, non-cancerous skin. And so, yes, we want to add more tan. Yeah, we can apply blush and foundations and other things, but a healthy skin is always the best.
Very good. When we're looking at diagnosing skin cancers, are they always based on a skin exam, or are there other ways that we might spot or find out that someone's got skin cancer? And I particularly want to talk about melanoma in this situation.
Of course. So general rules, whether we're talking about non-melanoma or melanoma, as a general rule, any spot that does not heal, a bleeding spot, a changing spot, any different colored spot, right? Like a pink spot out of the blue, a rough spot, etc. They can fit into any kind of skin cancer, melanoma, non-melanoma. Melanoma specifically, we always talk about the ABCs of melanoma. A, asymmetry. B, border. If the border is not a nice circle, an irregular look to it. C, color. If the color is pretty dark or a variation in color, or suddenly the mole that was pink now is black. So a change of color. D, diameter, which is larger than a pencil eraser or 6 millimeters. And then E, evolving, changing, bleeding. And I always add two things. I always tell the patient, it's something you don't like or you've noticed that's bugging you or your partner doesn't like. I always look at those spots a million times more. Even though they might look okay, I keep like checking so they're guilty until proven otherwise. Because 50% of melanomas are actually detected by the patient themselves or by somebody there, like yourself, right? So these are the main rules. For other symptoms, it could be, again, like it could be something that's painful. So they've had this mole forever, but now it's painful, it's itchy. But classically, it is the skin exam. And so whether it's the primary care physician, who most of the time are able to help us diagnose so many skin cancers, or with our routine skin exams that we do in our clinic, sometimes patients are referred from other specialties like surgical specialties and others, saying that they noted an irregular spot or what we call like ugly duckling spot, which really looks different than the rest of the spots. Yes. And they're referred to us. We check them with our...
I like that, the ugly duckling. I like
duckling.
That phrase. Do you recommend for someone to draw on a diagram? This is where this spot's been for 18 years and it's never changed, versus this one over here is new and I'm watching it I've also wondered about, are you a fan of the patient or loved one photographing it to see this is how it is when I found it, and now a month later, this is what it looks like?
Without a doubt. We actually do that in clinic as well. So whenever we see a patient and there's a funny spot, we're not there yet to biopsy it, but we're like, something is weird about it. We take a picture, document the margins, the size, everything about it, and then we follow the patient up. This is something that patients also can do on their own when they're home and say, you know what, I have this. And we get a lot of messages sometimes like that. And then the other thing is in clinic, we sometimes do like a whole body photography technique where what we call like mapping, right? We check every single mole. This way, every time we see the patient, we actually open those pictures and say, oh, by the way, that spot is not there anymore, which is also a bad sign. Or there are new spots or something's changing. Yeah, it's absolutely true.
Yeah. How long would you recommend someone examine themselves something new or something that's growing before they do connect up with someone like you?
Ideally, for all the population, for a person who's never had skin cancer, to see us is every 1 to 2 years. Again, as I said, I'm a little bit more annoying and I tell them I want to see you every year, no matter what. We see the dentist at least every year. We see our primary care. So I would feel the same about the skin. From a patient perspective, when they're at home, I don't want that to be a source of anxiety to the patient. There's really not a strict guideline, but at least like not more than every month, right? So like, oh, I have this spot if they're showering, if they look in the mirror. And I always tell my patients that burden is mine to carry. You only tell me I have like a spot, I'm not sure what it is, and it has to stop there. I have to think about it, etc., because I don't want them also to be burdened by it. Because sometimes patients would say, wait, is this like asymmetric border? Just come to me. I will do that for you. Because it's a huge burden. And I know sometimes patients feel anxious about it. I don't want that. I just want them to say, please, I will have this mole to check. That's it.
So they're worrying and fretting and not enjoying their life, frankly.
Yes,
having good quality of life because they're fretting about something that they think is trouble, which may not be trouble at all. Once someone has had a diagnosis of one melanoma, what is the probability that they will be diagnosed again with another melanoma?
There is a higher chance, obviously, to having diagnosed again with another melanoma or actually non-melanoma skin cancer. So the surveillance is important after we're diagnosed with skin cancer. So for non-melanoma skin cancers, we see our patients every 6 months, at least for a few years after the diagnosis, because most of the time we find something again in one of the visits. They are slow-growing tumors. In melanoma, if it's an invasive melanoma, we see them every 3 months. And we do the lymph node check. We check every single area. We make sure they're up to date with all their health screenings and everything. Because yes, there's a chance that we might catch another melanoma and definitely a chance to catch a non-melanoma skin cancer because they're prone to it. The genetics is there. The exposure is there.
I think it's safe to say that most surgeries to remove skin cancers, no matter what kind it is an outpatient procedure, usually.
For sure.
Not something that an individual would need to be, in the hospital for several days, that this is in and out, let's get it out, right?
Get it out. In very, very rare instances where, let's say we have a melanoma that metastasized everywhere, so it went to like different lymph nodes and organs. Of course, that's a different process altogether. That's where the surgery team is with us, the oncologists are with us. But classically, almost all of our skin cancers that we're diagnosing in clinic, we're able to treat in clinic with a surgical procedure, and then they just go home and live life normally. So it's definitely treatable and curable way early in the disease. So prevention is key. So if we spot something, let's make sure it's not cancer and then forget about it.
If we can find more at the in situ stage 0 level, then that's the ideal. Absolutely, that's the ideal. Some people will say to me, well, I've already damaged my skin when I was a teenager. So what use is there in me protecting my skin now?
There's a lot because it's a cumulative exposure. The idea is that I get one blistering sunburn and that's it. Yes, of course, that's a higher risk, but also that chronicity of UV exposure, what we call chronic photo damage or chronic actinic damage, which predisposes us to having skin cancer. We see patients who are pretty young, but also we see patients diagnosed with their first skin cancer at the age of 90, because some of them are really slow, which is a good thing, but the chronicity of the UV exposure doesn't end. If it started, and even when you're like 65 or 70 or 80, I would still want you to be protected because it's just accumulating. The skin does not forget the sun. Our skin shows whatever happened 20, 30 years ago. very clearly.
Yeah, the gift that keeps on giving, huh?
Yes, yes.
I'll be looking at that.
I make it sound really miserable, but in reality, I promise, we catch it early. It's treatable. We enjoy our life. We enjoy our skin. We just have healthy skin and we move on.
Enjoy the skin you're in. Yes.
Yes.
Take care of it, or you'll not enjoy the skin you're in. I'd like to talk for a moment about research. And I know that you are very much involved with research, looking at the microenvironment of various skin cancers. Can you share some information with us about that, including clinical trials that may be of interest to some of our listeners? In particular, explain what the immune checkpoint inhibitor is. Sounds like something we would have on a spaceship.
Yes, it does. This is a new era of treatment for cancers in general, but specifically skin cancers. So a few years ago, our notion of treating skin cancers, specifically melanoma, has changed drastically. Before, if we had metastatic disease, we treat with aggressive treatments, aggressive radiation, aggressive chemotherapy, treating the cancer, but also I dealt with morbidities. The new era has shifted us from treating aggressively, attacking the cancer itself, as opposed to actually helping our body, telling our immune system, hey, there's a tumor, and you're just looking at it and waving by and leaving it instead of attacking it. And so there's an immune inhibition from the body's end to this cancer saying, okay, you know what? I don't care about your tumor. I'm just going to leave you, let you be. And actually, this was proven to be initiated by many factors, but also by the tumor itself. The tumor makes the body completely forget about attacking it, making the immune system just blocked. This is where the role of the microenvironment comes into play, because the tumor is there, so many proteins around it, so many factors on top of the tumor cells and on the immune cells and the stroma next to it. And everyone is living in harmony because the tumor actually is controlling all the neighbors. Immune therapy or immunotherapy or immune checkpoint inhibitor therapy means that I am going to tell the immune system that's already been blocked to release that block and attack the tumor. And so now the immune system's like, wait, actually you're a tumor. I'm going to attack you. What's been going on all this time? Scientists have developed so many treatments to target every single part of this tumor microenvironment or part of this tumor world, which is enabling now the immune system to attack the tumor instead of just being there. What we say is we're unleashing the immune system. We're breaking that bond. We're removing that brake on the immune system. And now the body attacks the tumor. There have been so many molecules that are involved. So when you hear anti-PD-1, anti-PD-L1, anti-LAG-3, which is more of a newer treatment, Hopkins proudly has been not only facilitator, but a true creator of most of these medications and these clinical trials that were done.
Sounds like we've been pioneers in this area.
Yes, we have been pioneers. Hopkins has played a pivotal role in the treatment of skin cancers, and we're very proud of that. Every few weeks or few months, we have some new drug that's trying to be developed against skin cancer, specifically melanoma, but also non-melanoma skin cancers. And so this is what is broadly meant by immune checkpoint inhibitors. There are so many immune checkpoints that we are trying to unleash so that our body attacks the tumor.
I think that that's something that individuals will say, well, finally, we're not looking at the slash poison burn method. Yeah. We're looking at using our own body to do its job for us. I often tell people, you think that your immune system isn't doing anything. It's doing something every moment. When you're stressed out, like let's say it's Christmas holiday and you're wrapping presents and you got food to get for people, you're going to 3 Christmas parties, you're holding one yourself. Next thing you know, you have a cold. And you'll say, I've just been so busy and now look what happened. I have a cold. And I'll say, that's not coincidental. That your immune system has been so taxed, it couldn't fight off you getting a cold. So I think, too, we need to encourage people to think about how are they spending their life. Not just their day, but their life. What are they doing to encourage their immune system to remain in tip-top shape so that it can support us in a better way? And then add to it these types of immunotherapies, which are as cutting edge as you can possibly imagine, right?
Life before immunotherapy, at least melanoma, before immunotherapy is a totally different world than our world now. There's never a right time to have melanoma, but if it has to be a time, this is the right time to have melanoma because patients who back in the day were deemed, okay, fine, you're done. This is not true anymore. Patients have metastatic melanoma, they're on immunotherapy, and they're living life as if they did not have anything, which is a breakthrough.
Yes, certainly is. I've also been reading that as we look in the future, comparing 2020 statistics on melanoma to 2030 projected and 2040 projected, that by the time we go through 20 years, from 2020 to 2040, the incidence will be 2.5 times more than what we're dealing with right now. That's pretty scary and worrisome. So I hope our audience listening realizes that now is the time, if you've not been taking good care of your skin, which is your largest organ, we do consider your skin an organ, it's not too late. What you do, you can also encourage and promote for other family members, certainly your children and grandchildren, so that you could be the pioneer in your family of we're going to do whatever that we need to do in order to reduce our risk and prevent us from needing to have big time treatment. If we could head this off at the pass, absolutely, positively. That's important for folks to know that this isn't a cancer in the statistics that's level and has been for some time, that it is on the uptake, and understandably so. Everybody get your sunblock on. Maybe we need t-shirts to say, get your sunblock on.
Yeah.
Is there anything else you would want to share with our listeners today regarding skin cancer?
Life is fun. Being outside is fun. And because we want that life to be even more fun, let's protect ourselves, use sun protection, and please feel free to reach out to your primary care, to your dermatologist, to anybody, any doctor you know. If there's any concerning spot, even though in your mind you might think, yeah, I'm sure it's a nothing. Hopefully it is a nothing, but that's the best thing that you want to hear. So enjoy life, but also take care of your skin.
Very good. Take care of the skin that you are in. Thank you ever so much, Dr. Sukkari. I want to thank everyone for listening to this podcast today as well. We hope you will join us next month featuring another Johns Hopkins medicine expert. To receive information about upcoming podcasts and other women's health content, please visit the A Woman's Journey website at hopkinsmedicine.org/A Woman's Journey to sign up for our monthly e-letter, read about upcoming podcasts and programs, and sign up for our upcoming free Conversations That Matter webcasts. Thank you so much.
Thank you.
Thank you for listening to A Woman's Journey podcast. Join me, Kelly Gear-Ripken, your host, Lily Shockney, and a variety of Johns Hopkins experts on the first Thursday of each month to learn about medical advances in women's health. A Woman's Journey acknowledges unrestricted educational support for our podcast, Healthy Insights That Matter from Astellas. For more information about A Woman's Journey's virtual programs occurring throughout the year and our monthly webcasts and podcasts, visit our website, hopkinsmedicine.org/A Woman's Journey. Like us on Facebook and Twitter, and visit our website at hopkinsmedicine.org/A Woman's Journey. Until next time, stay well.